Welcome, colleagues. It's great to have you here for this deep dive into cardiopulmonary bypass. You know, some people might think that once bypass starts, it's a quiet period for the anesthesiologist. But we all know the truth is exactly the opposite. That's when our vigilance has to be at its absolute peak, as we co-manage a patient in a completely artificial physiologic state. So today, we're going to dissect the core principles, the pharmacology, and most importantly, our response protocols for when things go wrong.
So here's our game plan. We're going to build this up logically, from the ground up. We'll start with the nuts and bolts, the machine itself. Then we'll get into the drugs and blood strategies we use to manage the patient on that machine. From there, we'll run through the worst-case scenarios and what our immediate actions need to be. And finally, we'll pull it all together and talk about protecting our patients' vital organs to optimize their safety.
Okay, let's dive right in. If you really want to master bypass, you have to start with the circuit. You have to know it inside and out. A deep, technical understanding of these components is the absolute bedrock for anticipating problems and keeping our patients safe.
So what are we really talking about with cardiopulmonary bypass? At its most basic, it's a form of extracorporeal circulation. We're literally rerouting the patient's entire cardiac output. We intercept venous blood before it can get to the heart, send it through our machine, and then return fresh, arterialized blood back to the systemic circulation. This creates a completely artificial state, and we, along with our perfusion colleagues, are in charge of every single part of it.
Now, this slide lays out the 7 core parts, but the really key insight here is to see them as a single, interconnected system. Think about it. Venous blood is drained into the reservoir. The pump acts as the heart, pushing it forward. It gets cooled or warmed by the heat exchanger, gets gassed up by the oxygenator, cleaned by the filter, and then sent back to the patient. A failure in any one of these parts can cascade through the entire circuit, and that can turn a routine case into a crisis in a matter of seconds.
So one of the first big decisions in how a circuit is built is the type of arterial pump. You've got 2 main flavors, roller and centrifugal. The roller pump is occlusive. It's going to pump whatever's in the line, whether it's blood or air. That makes it really risky for air embolism. The centrifugal pump is non-occlusive, which is safer from an air perspective, but its Achilles heel is retrograde flow. If that pump stops and there's no clamp or one-way valve, the patient's own blood pressure will drive blood backward right out of them, leading to rapid exsanguination.
The modern oxygenator is really a feat of engineering, but its design has a critical built-in risk. You see, unlike our own lungs, the membrane in an oxygenator has tiny little pores. They're small enough to keep blood in, but they're big enough to let gas get pushed through. So here's the absolute key takeaway. If the pressure on the gas side ever, for any reason, exceeds the pressure on the blood side, gas is going to get forced directly into the bloodstream. And that means a massive, catastrophic gas embolism.
All right, so we've got the hardware down. Now let's talk about the software, how we actively manage the patient's physiology using that hardware. This next part is all about the critical drug strategies and blood management techniques that are just essential for a safe and effective bypass run.
This 4-step anticoagulation protocol is nothing less than a sacred, non-negotiable ritual in our field. We have to achieve full anticoagulation with heparin, and we have to confirm it with an ACT before a single cannula is connected to that circuit. Think about it. If you fail to do this, you get massive thrombosis inside the circuit, and that's a uniformly fatal event. And on the back end, that careful monitoring and precise reversal with Protamine is absolutely essential for hemostasis.
So this is our pro-hemostatic toolkit. Antifibrinolytics like tranexamic acid are really the cornerstone of how we try to conserve blood, and they're backed by Class I evidence. They work by stopping the breakdown of clots, which gets ramped up by bypass. Other drugs like DDAVP have more specific niche roles. And then you have the big guns, RVIA and PCCs. These are powerful rescue therapies we save for catastrophic bleeding, and their use is almost always guided by point-of-care testing.
So that begs the question, right? Why do we even need all these hemostatic drugs in the first place? Let's just take a second to really think about what's driving the coagulopathy that we know is an inevitable consequence of putting someone on bypass.
Well, it's really a multifactorial assault on the entire hemostatic system. As you can see, it starts right away with hemodilution from the prime, then you have contact activation from all those foreign surfaces, you have the enzymatic slowdown from hypothermia, the platelets getting beat up by shear stress, and of course the massive dose of heparin we just gave. It's a perfect storm of issues, which is exactly why we need a proactive, integrated blood management plan, usually guided by something like TEAG or RO10.
Okay,
This is one of the truly classic debates in perfusion science, alpha-stat versus pH-stat, and it has a direct impact on the brain. With alpha-stat, we basically let the pH drift alkaline as the patient gets colder, which preserves cerebral autoregulation. With pH-stat, we fight that drift by actively adding CO2 to the circuit to keep the pH at 7.4. All that extra CO2 is a potent cerebral vasodilator. For adults, the evidence is really clear that alpha-stat is the way to go, but for kids, pH-stat is often preferred.
Now, let's go to the far end of the spectrum and talk about the most extreme application of this technology, deep hypothermic circulatory arrest, or DHCA. Here, we're not just bypassing the heart and lungs, we are stopping everything, all circulation. The patient is cooled down to maybe 15 degrees Celsius, at which point the brain's metabolism is so slow, it can actually tolerate a period of complete global ischemia. This gives the surgeon a bloodless field to operate inside the aortic arch.
So here's the crucial difference. While DHCA and conventional bypass use the same basic machine, their goals are completely different. In a standard bypass case, our goal is continuous perfusion. In DHCA, our goal is to create a safe period of no perfusion. This puts the brain at a huge risk and requires incredibly careful temperature management, which really sets the stage for the kinds of high-stakes emergencies we're going to talk about next.
All right, let's shift gears. We're now moving into the scenarios that, frankly, keep us up at night. These are the low-frequency, high-impact events that demand immediate recognition and a coordinated, almost reflexive, team response. This is where our deep understanding of the whole system is really put to the test.
0.08%. That sounds tiny, doesn't it? But an iatrogenic aortic dissection that happens during cannulation, or right at the start of bypass, is one of the most feared complications in all of cardiac surgery. It has an incredibly high mortality rate, and as anesthesiologists with our eyes on the TEE, we are often the very first people to spot it.
This is the image that makes your heart stop. You've just gone on bypass, and suddenly this new intimal flap appears in the aorta. The jet from the cannula has literally torn the aortic wall, and now the pump is perfusing a false lumen. That means the brain, the heart, pretty much every vital organ is probably getting no flow. This is a stop-the-pump emergency, and it demands immediate, coordinated action.
Your response here can't be a thought process. It has to be a reflex. The second you suspect dissection, you have to speak up, loudly and clearly. Stop the pump, stop the damage. From there, the focus immediately shifts to supporting the surgeon as they figure out a plan to recannulate and get flow back into the true lumen as fast as humanly possible, with us guiding every step with the TEE.
Okay, here's a classic scenario for you. You've just gone on bypass, and boom! The right cerebral oximeter reading plummets, but the left side is stable or maybe even goes up. What's the first thing that pops in your head? What does that tell you about where that aortic cannula is pointing?
This pattern is screaming arterial cannula malposition. What's happening is the jet from the cannula is shooting directly into one of the head vessels, usually the innominate artery. So you're hyperperfusing the right arm and the right side of the brain and hypoperfusing literally everywhere else. This is another critical situation where you've got to speak up immediately so the surgeon can physically reposition that cannula and restore balanced flow to the whole body.
Air in the arterial line is an absolute nightmare. It can come from outside the patient, like an empty reservoir, or from inside, like nitrogen coming out of solution when we rewarm too fast. But the immediate response is always the same. Stop the pump. Stop sending more air to the patient. Then you put the patient in a steep Trendelenburg to try and trap the air in the aortic arch, away from the brain, and you slam in vasoppressors to increase pressure and literally squash the bubbles.
Now, it might be tempting to look at these kinds of mechanical failures and think of them as, well, historical problems, things that happened in the past. But this data tells a very different story. Mechanical and power failures, though rare, still happen. These numbers are a stark reminder that we have to have well-practiced emergency protocols, and we have to know exactly where that hand crank is and how to use it.
In a total power failure, that simple mechanical hand crank becomes the patient's lifeline. There is absolutely no time to hesitate. The response has to be immediate and practiced. One person clamps the line, another starts cranking the pump, and a third person starts troubleshooting the power. This is a scenario that we should all be running in simulation regularly, because hand cranking is exhausting, and if you don't manage it as a team, you'll get tired and your flow will become inconsistent.
Every single component in this circuit has its own unique way of failing, and each one presents with specific signs. An oxygenator failure, you'll see it as a failure of gas exchange. HCU failure, that impacts temperature. A tubing rupture, that's a catastrophic loss of volume. The key to managing any of these is a rapid, systematic approach. Recognize the signs, check the basics like power and connections, tell the whole team what's happening, and get ready to execute the specific backup plan for that failure.
This quote really gets to the heart of a more subtle but incredibly important challenge for us on bypass. The circuit isn't just a passive conduit for blood. It fundamentally changes the patient's pharmacokinetics. The second we go on bypass, drug concentrations are hit by hemodilution, temperature changes, and, most insidiously, by the circuit parts themselves sucking up the drugs.
In this chart, wow, this tells the whole story, doesn't it? The CPB circuit acts like a giant sponge for lipophilic drugs. Look at fentanyl. Up to 3/4 of it can be sequestered by the oxygenator. Propofol levels can drop by almost half just minutes after going on bypass. So the critical point is this: whatever dose of anesthetic was working before bypass is almost certainly not enough during bypass. This sequestration is a huge reason for intraoperative awareness, and we have to anticipate it by giving supplemental doses.
Okay, so let's zoom out a little bit, from the machine itself to the bigger picture of what bypass is doing to the patient's entire body. The simple act of blood touching the foreign surface of the circuit unleashes this massive systemic inflammatory response. Our management strategies, specifically with temperature and perfusion, have a profound impact on end organ function, particularly the brain and the kidneys.
When it comes to the brain on bypass, temperature management is everything. It's fundamentally about neuroprotection. And the story on this slide could not be more clear. Cold is protective and warm is dangerous. The single biggest takeaway here is that even mild hyperthermia, especially when we're rewarming, can turn a minor ischemic insult into a major, permanent neurological deficit.
And that brings us to what I like to call the rule of 37 degrees. It's simple. The goal is not just to rewarm the patient, but to do it slowly and carefully, and to actively prevent any overshoot. If you rewarm too aggressively, the brain can actually get warmer than the core body. And that state of cerebral hyperthermia happens at the worst possible time, right when the cross clamp is coming off and the risk of embolism is highest. We just can't let that happen.
After the brain, the kidneys are probably the next most vulnerable organ to the insults of bypass. Post-op AKI is a really serious complication, and it's tied to increased mortality. As you can see from the table, the risk factors are a mix of things the patient brings to the table and things that happen during the procedure. For us, our prevention strategy really focuses on things we can control: optimizing the circuit, keeping the mean arterial pressure up, and ensuring we have adequate flow. And, of course, minimizing the total time on bypass is one of the most powerful things we can do to protect the kidneys.
So, we've gone through the hardware, the pharmacology, the crisis protocols. Let's bring it all together now. Let's talk about the systems and, most importantly, the teamwork that we rely on to tie all of this together and ensure our patients are safe.
Modern CPB machines are incredible pieces of technology. They are packed with built-in safety features designed to mitigate the exact risks we've been talking about. Sensors for low levels, detectors for bubbles, pressure monitors. But, and this is a big but, it's critical to remember that these are tools that augment our vigilance. They do not replace it. We have to understand how they work, know their limitations, and be ready to act when they alarm or when they fail to alarm. Because at the end of the day, all the technology in the world is only part of the solution. True patient safety, that's an emergent property of a well-trained, communicative, and collaborative team. It's about building a culture where checklists are valued, protocols are followed, and every single person in that room feels empowered to speak up for safety. And there is no better way to hardwire those team dynamics than through high-fidelity simulation.
So, as we wrap up, I want to leave you with this final question to think about. We've got the technology, we've got the protocols, but beyond all of that, what is the single most important non-technical skill that we bring to the table to prevent a disaster? Is it our communication? Is it that unwavering situational awareness? Or is it calm, decisive leadership when a crisis hits? I think the answer is probably a blend of all three, and mastering them is what elevates our practice from a science to an art. Thank you so much for your time today.